Please welcome Dr. R. Vinayagamoorty. He has done MSc and PhD in medical biochemistry, presently working as professor and head of biochemistry, Government Indira Gandhi Memorial Medical College and Research Institute, Puducherry, India. He is principal of Allied Health Sciences Health Department of Biochemistry and in charge of laboratory services. His area of interest are cell signaling, diabetes and nutrition. He is PhD guide and over 23 publications on his name. I welcome Dr. Vinayagamoorty on stage. Sir, please.
Very good afternoon. Thank you, sir, for your kind introduction. On outside, I thank Mindray for this opportunity. My topic for the discussion is on importance of anemia markers. Yes, anemia is the global problem. It's defined as there is a low hemoglobin concentration when compared to the reference range. It affects almost 1/4 of the global population, even though there are a lot of sensitization programs have been conducted. It affects all the groups, invariably age, sex, whereas the vulnerable population is the preschool children in the underdeveloping and developing countries. The most important about the anemia is early detection, which will help us the better treatment for the prevention of the further complication as well as the mortality. It can be defined as based upon the hemoglobin value, that is depending upon the age between 11 and 13 grams. We are seeing here the hemoglobin cutoff values for the different ages, that is ranges from 11 to 13 grams as a reference range. Going to the topics as a laboratory marker for anemia. What is a marker in general? When we come to a laboratory marker or a diagnostic marker, a marker should qualify these parameters. That is, it should give us a diagnostic indication and it should tell us the disease severity, what stage is the disease, and most importantly the cause, that is the differential diagnosis. The particular analyte or the parameter will tell us the root cause so that we can treat based on the root cause. Next, the particular parameter or analyte should able to tell us the success of the treatment as well as the prognosis. So these are some of the important qualities for a laboratory markers. So coming to anemia or any markers, if you say, when it comes to diagnostic, there are 4 important quality we are taking. One is specificity, whether it is so specific to that particular disease. Second, sensitivity, whether it can pick up at very low level or even at higher level with the available techniques or the instrumentation. Most importantly, it can be available to the rural population, whether we need to have a very good setup with the experts are required to operate those particular instrument, that is availability as well as the affordability. So to get a diagnostic marker, these are the basic requirement, and whether it can tell us the disease severity, whether it is a mild stage or moderate or severe, that is important. Coming to the differential diagnosis, in case of anemia, whether it is the nutritional cause or it is a genetic cause or it is a hemolytic anemia or other the comorbidity conditions like thyroid, etc. Then it should tell us whether the treatment is success or the same particular marker can be used for the follow-up study. So these are the most important quality that is required to declare a parameter as a marker for the particular disease. What we look for anemia, in this case as a marker, we always go with hemoglobin as a marker. Whether hemoglobin satisfy all these quality for a marker of a anemia, the answer is yes, it is an important diagnostic marker. It is specific for anemia, yes, we agree. Sensitive, yes, with the available methodology, it can be picked up even at a lower level and even at a higher level, it can be extrapolated. Availability even at the rural setup with the pH level, we can estimate anemia. With hemoglobin, we need not have a technologist, highly qualified, experienced technologists. Yes, availability is fine with the reasonable cost. So, based upon this, and hemoglobin is a better diagnostic marker professionally. Whether hemoglobin can tell us the disease severity, the answer is yes. Based upon the hemoglobin level, we can say the particular person is with mild or moderate or severe anemia. Accordingly, we can take a call on nutrient correction or whether we need to supplement iron or transfusion is required. Yes, here also we are succeeded with hemoglobin. Coming to the differential diagnosis, there is the problem. Whether with the circulating hemoglobin level, whether we can identify the root cause, that is the differential diagnosis for the treatment, there the hemoglobin fails. We cannot find only with hemoglobin as a diagnostic marker whether it is a nutritional cause or it is a genetic cause or it is like a hemolytic anemia or the factors that can be influencing the anemia cause here. So as a differential diagnostic marker, there is a problem for anemia, but to some extent hemoglobin can be used as a prognosis as well as the management marker, even though it takes some time to pick up, to show it at the circulating level. So taking all this into consideration, yes, hemoglobin is a gold standard marker for the diagnosis, but when it comes for differential diagnosis, it has its own limitation. So to understand the pathophysiology and for the treatment, the differential diagnosis of a particular disease is very, very important. Hence, we need to have the other markers for the differential diagnosis of anemia apart from hemoglobin. So, what are the other laboratory markers available for the differential diagnosis of hemoglobin? For that, you should know what are the causes of anemia. General causes of anemia, we have nutritional cause and we have the genetic cause. Anemia can be due to prolonged inflammation or due to the chronic diseases, or it can be the physiological others. So taking all this in consideration, it is a multifactorial disease with a different etiology. So we cannot rely upon again a single marker for differential diagnosis. Of course, hemoglobin is a gold standard marker. For differential diagnosis, we need to take a pool of markers along with our clinical observation to have a confirmed differential diagnosis. Most importantly, each laboratory or each setup should have their own protocol for the differential diagnosis of the anemia. Why I am saying this, anemia varies from regions to region. Even in India, if you go to Orissa, there thalassemia is common. To my place, in case of Pondicherry, it is alcoholism is very common there, and many people suffer by, we have malaria and as well as filaria there. So we should have our own laboratory setup with the available markers to differentiate anemia. General approach, how we can go for the differential diagnosis, we should start from age and sex, whether they are the preschool children or sex, male or female. Socioeconomic status is very, very important here, including where they are living, high altitude, or whether pregnant women or they are smoker. In consideration with the geographical distribution, you take all these things into consideration. Clinical examination is most important. Based on this, first you go with your hematological analysis, hemoglobin, RBC and other parameters we can take up. There we can have some differential diagnosis, that is based upon our clinical examination and with our hematological markers. Definitely we can have a professional diagnosis with some amount of differential diagnosis. From there we can deviate whether we wanted to go for the nutritional marker or inflammatory marker or infection or genetic markers or others, right? So there are so many hematological markers. The basic things, we can stick with the basics, start from the hemoglobin, and we can go for RBC and we can go for PCV, MCV, MCH. From here we can, if the hemoglobin level is low, it is anemia. Hemoglobin level is low, it is anemia, and if there is a low PCV as well as MCH is low, there is a microcytic anemia. where there is a nutritional cause. It can be due to iron deficiency or folate. If there is a more level of MCH and other things, then definitely it is a B12 and folate deficiency. So here there is a differential diagnosis you can come. From this, definitely you can go for the nutritional markers. Nutritional markers start from the iron studies, hemoglobin, serum iron, ferritin, transferrin, soluble transferrin receptors and total iron binding capacity. Here you can see the iron storage protein ferritin. Yesterday we had a discussion on ferritin, whether ferritin is a marker for anemia or it is an inflammatory marker. That was the discussion. In iron deficiency anemia, there is a lowering level of ferritin in concurrence with hemoglobin. So when there is a low hemoglobin level and low ferritin level, definitely it is an indicator of iron deficiency anemia. So if there is a microcytic picture in the smear and there is a iron status is low, there is indicator of you have the microcytic anemia. Next, apart from your iron studies, we can go for the vitamins. The most important vitamins, you have folate B12. Not only the folate B12, and we should look upon the intrinsic factor that is very much essential for the absorption of B12. So these are the vitamins that are available for us as a marker for the nutritional evaluation. Is this enough? Is this enough only with the iron study and vitamin B12 folate? Are we satisfied? There are other markers that are available for us. You can go with vitamin C. Many of us are missing vitamin C because vitamin C is very much essential for the absorption of iron because iron is absorbed in the ferrous state. Most importantly, vitamin C keeps your hemoglobin in the functional form, which can convert methemoglobin into the normal hemoglobin. So vitamin C levels are very much important. The another important vitamin that can be estimated in anemia is the pyridoxine, that in vitamin B6, which is a very important cofactor for the hemoglobin synthesis, that is ALA synthase, that is requiring vitamin B6 as a coenzyme. And another important thing, vitamin B6 is required for the globin chain synthesis. Similarly, your riboflavin is required. Zinc is very much important. Why? Because it is a coenzyme or the cofactor for the RNA polymerase, and zinc protoporphyrin is one of the important of heme synthesis. Apart from these vitamins, recent studies are reporting vitamin A has a role in nutritional anemia, even though the exact mechanism how vitamin A causes nutritional anemia is not known. There are reports coming out that your RXR receptor is one of the control point for the ferritin expression. So what they are saying, in vitamin A deficiency, there may not be a nutritional deficiency of iron, whereas there may be a functional deficiency of iron in case of vitamin A deficiency. So the nutritional markers for us for the anemia start from the iron studies, then go for your folate B12 and intrinsic factor. Apart from that, we can go for vitamin C, pyridoxine, riboflavin, zinc, if required, vitamin A also. Right? Next, anemia due to inflammation. There are so many inflammatory markers available for inflammation analysis. How inflammation causes anemia? Because prolonged inflammation can impair the bone marrow function. Prolonged inflammation can impair the bone marrow function. Thereby, it can affect the hematopoietic system. There may be anemia. So there the nutritional status may be normal, whereas because of inflammation there is anemia. Yes, here we should cautionally correlate with ferritin level. There we have seen ferritin is low, here we are seeing the ferritin is high. That is why the discussion came yesterday, what is the role of ferritin, whether it is an inflammatory marker or it is an anemia marker. It is so simple, you go with your hemoglobin level. Hemoglobin is low and ferritin is low, it is iron deficiency anemia, no confusion. Your hemoglobin is low and your ferritin is high, that anemia due to inflammation. That is very simple as it is. So these are the various inflammatory markers available for anemia. Then anemia due to chronic infections. Some of the chronic infectious diseases including HIV, that what is predominant in case of Pondicherry, we are seeing many anemic cases. Tuberculosis, tumors, rheumatoid arthritis, malaria, of course, where you can go for smear studies, and hookworm infection, where we can screen for surface antigen and stool examination. These are the various markers available for anemia in case of infections. Yes, hemoglobinopathies, sickle cell anemia and thalassemia, it can be screened based upon the blood smear, and some of the HPLCs even they can pick up the various forms, isoforms of hemoglobin, including sickle cell, and other HBE can be estimated by using HPLC system, and you can go for genetic screening to rule out sickle cell anemia and thalassemia. Of course, the most important as well as the confirmatory analysis your hemoglobin electrophoresis for the confirmation of sickle cell anemia and thalassemia. Other markers, of course, all these things are normal. Is there any comorbidities? Yes, we can look upon the physiological laws, menstruation and pregnancy. Pregnancy is always, there is a high demand for iron, which can be a cause for anemia there. And G6-PDH deficiency, which is very important for your HMP shunt pathway, where there is NADHP is produced to keep the methemoglobin into the normal hemoglobin, as well as prevent the hemolytic anemia there. So we should screen for G6-PDH, and gastric and intestinal bleeding we have to check in. And associated diseases, thyroid. Thyroid is very much important. The previous speaker morning here spoke about association of thyroid with pregnancy as well as anemia. So in pregnancy we have both hypothyroidism as well as anemia. Apart from thyroid, we should always look upon the renal function. Why renal function? Because erythropoietin, which is an important stimulator for the erythropoiesis, is synthesized and secreted from kidneys. So we should screen for renal function also. So apart from this, we found an interesting study that to answer the morning discussion, in hypothyroidism we found there is low ferritin level that leads to iron deficiency anemia. We came up with this proposal, and there are recent reports that ferritin is one of the downstream gene that is controlled by thyroid hormone. So in hypothyroidism, what happens? The ferritin expression is lower. That is why in hypothyroidism, which is common in pregnancy, there is iron deficiency anemia. Here, whatever the iron supplementation you give, there won't be any response unless and until you correct the thyroid. And another mechanisms, what is happening in case of your hypothyroidism, there is achlorohydria. You need hydrochloric acid to liberate free ions from the dietary ion. Most of the dietary ions are always in combination with the protein bind ions. So HCl is very much important for the denaturation of protein, so that ion is released, then it is reduced into ferrous form with the vitamin C. So in hypothyroidism, iron deficiency anemia is common. Why? Because iron deficiency anemia is very common in pregnancy. You have to screen for both ferritin as well as your thyroid case here. And here we want to compliment Mindray for supporting us with the instrument, because we are from a government setup, we have only the limited resources. During COVID time, they have given us CLIA with the subsidiary rate. As even today, they have promised us to support with some of the reagents for our research purpose. Thank Team Mindray for your social schemes, which is helping to the government sectors. So to conclude, anemia is the most common, affects many groups with different etiology. So you cannot go with a single parameter for differential diagnosis. Of course, differential diagnosis is very much important. So we have to make our own algorithm depending upon our socioeconomic status as well as our distribution. In general, go with the clinical examination, start with the hematological findings, then follow with the biochemical and immunological markers. If you are satisfied with all these things, you can look for the other causes. Thank you.
Thank you. Is there any questions?
Nice Nice presentation, sir. There is a lot of buzz around anemia of chronic disorder, a new marker called hepcidin. Is there any thought on you for specifically or any experience with you for the hepcidin level relation with the chronic anemia? I mean chronic anemia of chronic disorder.
Yes, sir. Anemia of chronic disorder, anything that is chronic, it affects the hematopoietic system. Anything which is chronic that affects hematopoietic system through inflammation. Especially in HIV, the entire hematopoietic system is getting affected. That is why in later stage of HIV we can appreciate there is pancytopenia.
Not HIV, the serum hepcidin,
Serum?
the new marker which is coming up. It is not yet approved, but there are a lot of people, I mean, lot of clinicians aware of this thing, and they are telling us to do this marker.
No, sir. I have not much information about hepcidin. Anyone can throw light on that role of hepcidin as a marker for anemia?
Hepcidin is actually inhibiting the proximal iron absorption. So that way it is a surrogate marker, but it has not yet been developed for clinical use. So we can go for these surrogate markers like hepcidin, ferroportin, but right now there is no platform for that. Basically, whenever we are talking about iron studies, we are still relying on a three-way process of iron, ferritin, transferrin and TIBC, of course. But hepcidin and all, it's not yet commercially available, but if it acts also, it will be an indirect surrogate marker. So that can be done.
See, the most important thing of any marker that we want to develop, how much it is going to solve our purpose and how superior it is when compared to the available markers. Whether you can pinpointly make any differential diagnosis based upon the particular marker that is coming up. Yes, yeah, that is what.
Basically, what he is talking about anemia of chronic disease.
Chronic
So
disease,
for anemia of chronic disease diagnosis, iron and TIBC is actually both are getting very low, along with a definite history of a disease, itself can give you a diagnosis of a ACD.
Definitely.
So there is no other need for a new marker for substantiate something when in that condition. Anyway, let's see if it comes. So we don't know anything about it as such. I have a question, sir.
Yes, sir. Yes.
Suppose a patient, a smoker, a developing CKD stage 2. So that means the condition when erythropoiesis is also getting affected gradually. But because of being smoker, he is already having a reactive polycythemia and hemoglobin level up around 15, 16. So what will be the way to diagnose that this patient is getting affected on his hematopoiesis? Because having erythropoietin compromise, he will having less erythropoiesis, but already he is having a good amount of RBCs and everything because of the reactive polycythemia. Yes. So this masking area of one another is actually masking one another effect. Na? So is there any definite marker where I can get through the process that yes, the hematopoiesis and all these effects are getting affected by this time? Because seeing the CBC and all these, yes, sir, it is difficult to diagnose in that particular condition. So that's just a query, if there is a...
In smoker, actually, we should go only with hemoglobin level with the clinical examinations. Because no other biochemical parameters, especially ferritin and other things, are not affected. So better thing, you go with the clinical examinations in case of smoking. The clinical examination is very important. What we are observing in our hospital, especially the trainee doctors, interns, as soon as they see the hemoglobin level, next they will take ferritin, folate, B12. So they won't wait for the smear studies.
But actually the problem where I was pointing out is that the ferritin will remain intact because iron indices are all okay now. There is no iron
sir.
deficiency.
Yes.
It's only erythropoiesis which is going down. That is why patient is developing anemia gradually, particularly on CKD, ongoing CKD. At the same time, he is having polycythemia. So
Definitely,
these
sir.
particular area, I think, very difficult to diagnose.
Definitely, sir. So for smoking, there is no specific biochemical markers. Even otherwise, for treatment strategy also, what we are going to advise him is to stop smoking, because we are not going to give any supplementation also. So we need not require a marker for that.
Thank you, sir.